Good morning. I'm Dr. Bill Wyatt again, and I'm going to talk to you about the birth of this intruding arch that I came up with back in 1971. And what makes it work is similar to what really makes this carriere motion appliance work. And I want to go through the intruding arch first and show you that, and then we'll try to tie in the relationship between the two. Uh, now, I've got to tell you, I'm a general dentist, and I've limited my practice to nothing but orthodontics back in 1970, and I did a good bit of orthodontics and work like that back in 1955 through 1970. Uh, anyway, I'm, I'm getting old now, which is pretty obvious, and I wanted to dedicate this video to two good friends of mine. These are pediatric dentists. One of them is Dr. Lenny Carapizia, and he is right out of the Boston area, and the other one is Dr. Leonard Ed Gonzalez, excuse me, in Florida, around the Tampa area. Both of these gentlemen are instructors in the AOS, which is American Orthodontic Society, and I'm strongly pushing this organization. If you're a pediatric dentist or a general dentist, or as far as that goes, anybody that's doing orthodontics and you're not in a good organization, get in the American Orthodontic Society. We have some wonderful instructors that are knowledgeable and will know how to teach and know how to teach you some real good, solid orthodontics and stuff that lasts and is good. Both of these gentlemen that I'm dedicating this to are instructors in the American Orthodontic Society, and we have a lot of good people that are dedicated to teaching you orthodontics. Anyway, I've said enough about that and get on to what we really wanted to talk about this morning. I'm going to go through these. I just got a few slides on this case, and I'm going to go through them and do a little bit of drawing on there to explain this carriere motion appliance. I don't have a good up to the deal picture of it to show you. Start off with, this is where this knowledge came to me back in 1971. This young man came into me 6 months earlier than this and wanted to have braces put on his teeth. He had this deep bite, and otherwise he had a good class 1 relation in the molars and bicuspids. It's amazing, and have this deep bite with not any more crowding he had of his lower anterior or upper anterior. Anyway, he's a nice guy, but he's just a kind of a hippie kind of fella, and we got him in, and I think we agreed to what we were going to do and all this, and I needed to open his bite, so I put 6-year molar bands on him, and I banded. This was before we had brackets. Now we banded the upper 6 anterior teeth. Of course, we had to put separators in and send him out for a while, few days and came back, and we put all this stuff on his teeth, and the 6 bands on the lower and 6 on the upper. And then I hooked up these 2 little arch wires that I'm going to show you here. They were just simple round wires, had a little curve in them back here at the back, a little circle, and they were both, way up above the teeth. We had to come down and tie them to the upper front teeth, and bring them up and tie them to the lower front teeth. And that was the force that was in there to open the bite. And I had them attached to the 6-year molars back here. This was in the tube of the 6-year molar, and the teeth would be down here, and we would bend the wire down and hook it to that, and then this one we'd bend it up and hook it to these teeth. And that's all that was in this man's mouth. Now, what happened, he left, and if I ever saw him a second time, I don't remember seeing him anymore. And he just disappeared. We couldn't locate him. We thought, well, he's just gone. But lo and behold, 6 months later, he shows up and comes in, and so one of the ladies puts him in the chair back there, and came up to me and said, "Dr. Wyatt, you better come back here and look at this guy's teeth." And so I went back to the room and looked at his teeth, and you can't, let me see, I'll go back to this picture. You can't see good in here, but these upper front teeth wouldn't come together. They had about a millimeter space in between them. He couldn't bite with his 4 front teeth. His cuspids he could touch together, but not his 4 front teeth. Now let me go back, and this is the model of his upper, just showing it from the front. I'm going to show you the side in a little while. Here, I'll show you some stuff in his mouth. But you can hardly see his lower anterior teeth in here. So they are up in here somewhere, like that. Now these 2 arches we put in were way up like this, you see. And we brought them down and hooked them to these teeth. And this wire went down here somewhere, and we brought it up and hooked it to these 6 anteriors and these 6 anteriors. And he comes back in 6 months' time and can't close these teeth together. I'll show you. I'll go to some pictures of that and show you that too here. Now, let me see. Okay, here it is. He came in this way, and I got in. I didn't have any earlier pictures. Seemed like I don't know what happened. I don't ever start them without doing all this stuff on them. But anyway, here are his teeth after 6 months. I mean, I never saw the guy for 6 months, and he came back like that. Now, it takes about 4 times more force. Like if you take, let me erase this and put a clean sheet up here. If you take one tooth over here like this, and another tooth over here and they're in the same kind of bone structure and whatever. Everything's exactly alike, and we push this one up with a force. From this one is being pushed down force. Now, that's what's happening in here. We've got these molar teeth down here, and say this is the lower molar, and it's coming over here. It's pushing. Well, I'll change that. I'll have to draw it over again. If it takes 4 times the force to intrude this one into bone as it does to extrude this one over here. Alright, so these molar teeth back here were being forced down, or excuse me, the lower one was being forced up, the anterior teeth were being forced down. It's 4 times harder to force one down than it is to exfoliate the other one and to force this one into bone. So it takes a whole lot more effort for these teeth to stay there and these to intrude like that. And it's right reverse of that up above, of course. Now these molars back here are going to be pushed down with exactly the same force that all these teeth are going to be pushed up here. These teeth right here will be pushed up, and these will be pushed down. These are being pushed down. So these 2 molars are going to be pushed together with the same force. It's these 2 over here, of course. It's you've got 4 molars pitted against 6 uppers and 6 lower teeth. Now you didn't raise the cuspids very much, but all these others you raised quite a bit, picking them up. Now, just to kind of bring you back to this, there's where they went from. See, in other words, these teeth went up, and these teeth in here went down, and these teeth on the upper molars were pushed down with the same force that these 6 were pushed up, of course, on both sides. And down here, as these were forced down, these were forced up. In other words, these molars are being pushed together, and these anteriors are being pushed apart. And in 6 months' time, that happened. Now, I learned a tremendous amount from this simple thing that happened. I could not do this to a person, but I put this on there, and I wish I had better documentation of his going away before we started everything, but I didn't take that good a records back in the 70s when he started that. Now, let's see. We go back to where he's open. Alright, let's go through some of the other stuff. There's some important things to show you in here. Alright, the cuspids did not raise up much. They changed though. See, so this cuspid leaned back, and this one leaned forward as these other teeth went down. This was the wire was coming close to them, coming out through here. But that little gentle force with a little bit of a circle in there to make it more gentle forced all 6 of these teeth up and 6 of these teeth down and opened his bite, and the guy couldn't bite. Now he chewed real good. If he had not chewed and bite and hold these teeth in place, the vertical height of his face would be much, much higher. Now, if you look at the vertical height of his face in here, no, I don't want to discard these. So it threw me back. Now I'll have to go back into PowerPoint, and I'll have to get my little red marker back. Okay, we're back in business now. Okay, where were we? But anyway, this is amazing that we got that kind of action out of 4 molar teeth. And that said something to me. Why don't we utilize this occlusion is why it worked. If he hadn't been biting, it would have opened his vertical tremendous amount. But he bit and he chewed. And that's why your carriere appliance works too, because it's hooked up to the 6-year molars, and it pulls class 2 elastics down against this one. Apparently it's put on young kids and they don't have a second molar, so I'm sure they're using a hook up to the molars, and it goes from the cuspid back to the molar, and these molars hold their position pretty well, and that's why it backs this up and this moves forward. But the carriere appliance is just like any other jaw propulsing appliance that you have, the Herbst appliance or the bionators or anything that propulses the jaw forward. We've been doing this repairing or helping TMJ problem cases for 30-something years, and it really works. We bring their jaw forward with some kind of ramped appliance to pull the head of the condyle forward to get it off of the retrodiscal tissue, where it's putting pressure and causing TMJ problems for many people. And that is a gratifying thing to be able to do to somebody. Then you have to make their teeth fit after you get them out there. Now that's where it separates the boys from the men, is making those teeth fit in that jaw position. So anyway, we'll get on back to this particular appliance that we're kind of to explain why it works and it does work. Okay, all right, let's go on to some other pictures here. Now we'll go back here. You see this molar has changed to some extent. If you go back, the angle of the occlusal plane on this molar, something like this, and this one is something like that. But they were a little different angulation back when we were in the, let me see, models. Okay, all right, look at the angulation of the molar here. It's like that. This molar has the 6 keys of occlusion. You got your distal buccal cusp of the upper 6-year molar is contacting the medial buccal cusp of the lower second molar, see. Now this will change. Now this upper molar, we're coming off of here with this arch wire that we had up here, and we pulled it down there, so that arch wire tended to move this tooth this way, see, and the tooth will change about this angle, and this was this way to start with, so they're going to be about that much intrusion that's going to push this cusp down here. Now this bottom tooth, it's going to pick up and hook to pull this down to intrude this. It's going to push this tooth up right here. So you got a arch wire in here that's tended to do, we raised it up over here, so it's tended to push this tooth up also. So it's going to change to some extent right in here also. But what it boils down to, virtually all the occlusion of all these teeth that came together here is right here on this spot. This tooth goes down, this tooth goes up. Okay, these teeth come in contact like mad here. And so the occlusion holds these teeth in place while all these teeth go up and all these go down right here. Now that same mechanics is working on this carriere appliance, you see. It pushes back on this molar. They put a, we'll get into this and show you a little bit more in just a few minutes. Alright, this side over here has got the same thing. And now look at these molars later. Alright, here this shows the molar. There's no big thing showing on that. Down on the bottom it's amazing they're not more crowded than that. And this is his lower arch before we started anything. And there's the depth of bite. And it comes out where these teeth don't even touch right in here. And then this molar is angled this way instead of that way. And this one down here that's going back here, it's picked up even more in the front. And these teeth are coming together with a tremendous amount of force on them. I imagine these get a little sore right in here. But these teeth don't take much the pressure in here, but that holds those molars in place while these go up and these go down, and that same mechanics is what keeps this carriere appliance going, and that has a lot to do with it. Okay, this is the other side of that. Now there's the guy. I don't know whether I've got another picture or not. Yeah, there we are, and you can see him. It didn't increase the vertical height of the face much, but I'm sure that it is a little increase in here because these molars went together some as this went up, and whatever those molars went together, this face will increase the vertical height of the lower third of the face. Now there's some close-up pictures of it. You know, when it is amazing what those two little wires, the force they had to bring these teeth down and these teeth up like that. It's amazing. Now that mechanics is what helps this carriere appliance to work, because this occlusion hits those teeth back there. If the kid is not occluding good and is sitting there breathing through his mouth and swallowing him properly with an infantile swallow pattern, this carriere appliance could increase the vertical height of the face a lot. So you have to really realize that if you're using a lot of it. But it's a smart appliance. A guy picked this up. Now this was, let's see, in 1971 when I learned this, and that's 29 years, and then it's 2017 right now. Well, while I'm saying this is 2018, so we had several years, but I did not pick up how you could market this. Now some people are interested in marketing, and they learned how to make this nice and slick deal and sell this thing, and it is a good appliance and it works, and it's really convenient and easy. But you could do the same darn thing if you put one of these big daddy arch wires in there and put a hook on it out here, and maybe you'd have to bond it to this cuspid so it would carry the cuspid root back with it. Now they put this ball joint on there, which is is nice, you know. Okay, now there are the two wires again. Those two little wires did all of that. So it doesn't take a great amount of force. It's just a constant thing set in the mouth for 6 months, and it did that. The mouth doesn't look all that different. The photography is not that great back in 71, and here he is from the side, and this is from the inside. Now, it was 4 of 1971 when I did this, and I guess and this was the cephalometric picture of him here. I thought I had to, and apparently this is the last picture I've got on this, and so we'll go back to the first of it here and see if we can. This is not backing up for me. Okay, I'm going to try to explain this carriere appliance, and I'm not criticizing them at all. They some pretty smart men. Apparently, Dr. Carriere and his father was a orthodontist too, and they had seen some things work. Now this is not the first things. See, Tweed had a deal where, let me go back over here, and I'm going to have to get my pen back marking again. Dr. Tweed had something like this years ago before I came along, but I remember they had a stiff wire coming in here, and they had a hook on it, you know, and you put elastics on that, and that used the same principle. See this occlusion in here, chewing on these teeth, and you pull on them with a class 2 elastic right here that pulls this down. So Dr. Carriere, they came up with bonding this appliance over here, and this is rigid. But back here at the back, you got your molar coming down here, and you bond a deal on there, and your wire comes in here, and you've got a ball joint that's embedded into this, so that this out here goes up and down to some extent. And that's why I guess they call it the motion appliance, because as you continue with this class 2 elastic, which is coming down here, and you're pulling on it, you're pulling this down, this ball joint doesn't go down with it, and the cuspid is occluding, so it doesn't go down too much, and that puts all this force on this arch to bring it forward, and this one to go back, and that's what happens in here. But do not think that you grow a longer mandible because of this. You pull on these teeth where they kind of tilt forward, so they move forward some. The condyle, the head of the condyle up there, changes. I had breakfast with Dr. Harville in San Francisco years ago, and he had done a lot of work with these rhesus monkeys, all this stuff, and trying to grow these mandibles on them. And I talked to him at breakfast. I'd been to his lecture, and I said, Dr. Harville, did you get the jaw to actually grow longer or further out? And he said, not really. Said we postured the jaw forward. And one thing that happens, let me put a little deal up here. like the head of the condyle. Here's the fossa sitting. That's not too good of a fossa. The condyle is sitting in here something like this. Now the neck of the condyle will tilt backwards, and the jaw can move forward out here if you do this. The neck of the condyle, instead of, this is pretty bad artwork here, it kind of tilts backwards here. So you get some forward movement by the tilting of this. Now you go down here and your gonial angle will get bigger and lets the jaw come out further. This same thing happens with the Herbst appliance, bionators, any kind of jaw propulsing device. Plus your teeth may be like this. They may tilt a little bit in that direction, but the added amount of this will allow you to go from a class 2 to a class 1, and it just changes the position of the teeth, and you can come over here and have good interdigitation of the teeth, you know, fitting in there. It'd be perfectly fine, and this works good. But like a Herbst appliance, if you put it on with the kids in the mixed dentition and you take it off and he's still in the mixed dentition and the deciduous teeth don't have hardly any cusp on them, it doesn't work good. It'll slide back. But if you go in there and you have some good cusp on the teeth and you bring it out and your upper is fitting down in this, that's not exactly the way it is, but that tends to hold the case there. And if you hold it long enough, the condyle actually changes, this gonial angle changes, and it becomes stable. But you've brought a jaw forward without lengthening that jaw. You just tilted the teeth, you tilted this angle, and you tilted this neck of the condyle back here. So that's why it works, and this appliance does exactly the same thing, or very similar to what a any kind of jaw propulsing appliance does. But you correct the class 2 and get the kid corrected. Now I don't agree with, I've done a lot of this for years, but you've got a class 2 division 2 with the anterior teeth way out and the laterals out here somewhere, and the lower anteriors are sitting right up in here somewhere like this. I go ahead and open the bite before I try to bring them forward, and many times I pick these teeth up or bring them out here. I can show you case after case. One time I had one, the lower jaw was so glad to get free that it moved out here, and I had to put some class 3 elastics on it to finish the case up. That only happened one time in the 60 some odd years that I've been practicing, but all of them tend to move forward when you free up the mandible like here. So I'm gonna erase that and we'll go back over here. Now this appliance is really made good. It's made, you put this ball joint in here, you know, we can't do that ourselves, and it is neat, and you just buy it and you bond this on here and you bond that over here, and you've got this deal in here that will actually move up and down in this socket right here, but this is bonded to this too. So as this goes back, this bonded thing will tend to make the root go to some extent like the crown, but it won't go as much as the crown. The crown will go back and it'll tilt it a little bit. but it helps back up the root as you back this up, and the rest of these teeth go back. Now, if you were a mind to take advantage of this, what happens in here, you could put one of those big daddy arch wires on here, and you'd have to bond something onto this side, and it would go around to the other side and do the same thing and hook it up to elastics, and it will shove it back the same way. Now it won't be quite as nice as what you've got in that carriere appliance. I came up with I call the Mitchell appliance. Dave Mitchell, head of the department there at Emory, taught with me for several years, and I came up with this appliance and I dedicated it to Dave. He helped me a lot, and we went around the country together for a while there. Bless his heart. He was very smart, and he did the first bonded bracket case ever done, but he etched the teeth to put the brackets on the teeth, and back then etching was a no-no, and he thought if he published that they would just kill him for etching the teeth. But he did the first bracketed case that I know of ever was done. Dave Mitchell, the head of the department at Emory for about 17 years. And that's where my uncle taught at Emory too, and knew Dave. But Dave was a smart guy. Anyway, I wanted something to remember his name by. But that appliance does this very similar thing. I'm going to put a video on it after this and show you what it did. The only thing, it's more complicated, but it makes the person wear the elastic. Now with this carriere appliance, you've got to depend on that person to wear this elastic. If they don't wear it, it ain't gonna work. But if they wear it all the time, it'll work good. And if they chew good and have good function, it won't mess up the teeth. It'll correct the thing, and you hold it in place, and the pate can develop better. Then you can do whatever you want to with the teeth. You expand the arches, you can do any kind of regular orthodontic work, but correcting the class 2. But I tell you, I'd get the teeth out of the way if I were going to put one on and let it come up there. There's no sense. Maybe they get afraid if you take the teeth out of the way a lot of times, you don't even need the appliance. The teeth will come out on their own sometimes. As I told you, I had one that had to put a class 3 elastic on it because the doggone teeth came out so far. But every one of them that I've ever opened the bite on like that came forward to some extent, as best of my knowledge. So anyway, the carriere appliance, I think, is a good appliance. And they were smart enough to figure out how they could sell it. And they put a ball joint back here on this thing. You certainly can't make you a ball joint. So it's easier to just buy it and stick it on there than it is to do it yourself, but you could do it yourself if you wanted to. So I'll hush up, and I want to dedicate this to my two good friends, Dr. Leonard Carapizia and Dr. Ed Gonzalez. Both of them are sharp guys, and they're instructors in our American Orthodontic Society. And if you want to really learn orthodontics, go hear these guys talk. They are good, and I've known them for a long time. And we have several other good instructors, and they're not all pediatric dentists either. We have some very good general dentists that are excellent orthodontists, and they teach you a lot of good, solid orthodontics. So I'm going to shut up, and my wife said I've done talked too long. So I hope I kept you awake. Anyway, so I'll close out now. Thank you very much for watching, and I hope you get something out of this. So, bye-bye. Got to get this thing over here some way or another, and shut it down.